So let's understand step by step. So what do we need, and what are the obstacles that we have to exactly, reposition the maxilla posteriorly and superiorly. So what I think, first of all, that it's very important is that after we perform the incision, the blood supply of the maxilla will be guaranteed by a wide pedicle of the buccal tissues and also from the palatal soft tissue. So we'll have a guarantee about the vascular supply. So it's very important to, with the incisions, not do so big incisions. And at this time, so we need to understand also, and we need to know the anatomy. So this is a sagittal feel of the whole complex, and we can see posteriorly to the maxilla that we have the pterygoid plate. Attached to it, we have the medial pterygoid muscle, and over there we have the venous plexus, which is a very, very irrigated point. So we need to be careful about this anatomy situation. So every time we just go ahead and I do my osteotomy, my stap osteotomy, I just go with a curved osteotome into the pterygoid fissure, and I do, the fracture between the tuber and the pterygoid plate. So at this point, it's really, really important to angulate the osteotome from a superior to a inferiorly direction, because we just want to avoid, any kind of problems. If we just go on a superior direction, then we will have the maxillary arteries over there, then you'll have trouble. So just be sure to angulate it to the most inferior part of the pterygoid plate. And just be sure to put your fingers intraorally, because it will give a support for you, and then we'll be able to feel exactly the osteotome over there. So you just don't go through the mucosa and tear the mucosa. So after doing the posterior fracture, a septal osteotome will be carefully inserted along the septal crest of the maxilla under the intact nasal mucosa, in order to separate the cartilaginous and bony septum from the septal crest of the maxilla. So I just go ahead and do this fracture. And at this point, we'll be able to down fracture the maxilla. So it's very important to, at this point, or actually before we down fracture the maxilla, to speak with the anesthesiologist to work with a hypotensive anesthesia, because we'll need less bleeding to work back there. So it's very, very important in this situation. And at this point, after we do the down fracture, we'll be able to observe a very important vascular support over there, which is the descending palatine artery. So we'll be able to see it bilaterally, and it will be very important, if possible, to keep intact this artery, because it will be a very important vascular support to the maxilla, mainly in the cases that we do segmented maxilla. So it's very, very important to be careful at this point. After we do this, it's very important to understand that now we have the maxilla that is down fractured. So we just go ahead and mobilize the maxilla, and we need to push it back. So what is the first obstacle that we have there is the pterygoid plate. So we need to be careful and to do a horizontal osteotomy over there. I prefer, when possible, using the piezo, because we avoid bleedings over there. So I I think it's a very, very nice tool to work here. But sometimes it's kind of tricky to get inside all the way back with the piezo. Then I just go ahead and I use a 701 burr. I just go with all, you know, careful and try just to do a kind of a superficial osteotomy, and then I go with the osteotome, curved osteotome, and I just go tap over there, and I'll have the fracture of the pterygoid plate. And I just we have two options. I can just push it back through the muscle, and then I'll have enough room to the maxilla to go back. And the other situation, and actually here's the tomogram that we can see and in these kind of situations that we just break down and push it back. And the other situation is when we are able to remove this piece of bone. Well, actually, it's not so common, but when we need big movements, then sometimes it's necessary to remove this bone, and it's kind of tricky because we have the attachment of the muscle over there. So you gotta go with you know, careful using the bovie and just push, making a cauterization over there and just removing it slowly. So it's kind of tricky, but it's totally possible doing it. And this is the clinical situation when we remove it. So the other point of view that we need to understand is, okay, we can now move the maxilla to a posteriorly direction, but we need to go on a superiorly direction. So we need to understand that after doing the pterygoid bone plate fracture on the pterygoid fissure with the osteotome and separate from the tuber, we need to remember that we have all the surrounding bone around the artery. So it will be very, very important. And this bone is called the descending palatine canal. So in this article, it's very interesting because these authors could, you know, illustrate exactly what it's necessary to do, because we'll have the medial segment and we'll have the lateral segment surrounding all this, you know, and involving all this descending palatine artery. So it's really, really important to remove this bone.